So let me introduce you to my colleague and friend. I'm going to go back here now. Again, yeah, please get yourself some coffee and some refreshers in the back as well while Matthew makes his way up, because I'll probably be about 10 minutes doing his intro. I'm kidding, I won't. So Dr. Mathew Leonardi, who is a proud member of the SOGC, is a complex gynecology endometriosis excision surgeon and gynecologic ultrasound expert as well. He's a surgeon sonologist. So when we first met him, he went through our system and was recognizing that we needed to do better for imaging. I promise you that this is going to be both a entertaining but visually important meeting as well. He's an assistant professor at McMaster University. He's honorary adjunct lecturer at the University of Adelaide. Dr. Leonardi is on the World Endometriosis Society Early Career Board and a founding member of the Next Generation Committee at the International Society of Ultrasound in Obstetrics and Gynecology. He has presented his work locally, globally. I just saw him present in New Orleans, a fantastic lecture, and I look forward to your discussion. And Matthew, I'll monitor the questions. Come on up, and we'll go from there. So welcome, Dr. Leonardi.
Good morning, everyone. Thank you, Sony, for the kind introduction. Thank you to the SOGC for putting on this Endometriosis Summit. Like Sony, I'm just so happy that we're doing this, that we're talking about endometriosis in this platform with this number of people. This is a disease that I deal with in my patient population every single day, and like Sony, I'm obsessed with it. We're really immersed in furthering the care of our patients with endometriosis, and I'm really happy that you're here to learn a little bit more about that and do this together. Like Sony said, I did my residency at the University of Toronto, where I learned a lot, and I see some familiar faces here, which is lovely. But I realized in my residency some of the issues in the imaging space. I realized that we were really compromised by poor quality imaging being done in communities and in our hospitals, resulting in poor preparation for surgery and sometimes poor clinical outcomes secondary to those poor preparation moments. So at that point in time, I realized this is not acceptable and we need a fix for it. And part of my agenda was to then go to Australia, where I did my fellowship in minimally invasive gynecologic surgery and imaging. I scanned every day in the clinic and really mastered gynecologic imaging from an endometriosis lens, but also from a fibroid lens, a polyp lens, an ovarian mass lens, an adenomyosis lens. Imaging is relevant across every single thing we see, obstetrics as well, which I don't do anymore, but we are at the mercy of that. So it's really important for us, I think, to take control over it, to be the leaders, to be at the table, or to actually drive that bus. So that's why I'm doing what I'm doing as a surgeon sonologist, scanning all of my own patients, and now I think scanning for actually quite a number of you across the province in my ultrasound clinic space. So I'm really happy to talk to you today about endometriosis imaging, but if you have any questions about imaging for anything else, here or after, never hesitate to reach out to me because it's so important. Here are my disclosures. And so really the focus of this talk is going to be highlighting what the most recent SOGC guideline discusses with respect to imaging, with a heavy focus on ultrasound as the first-line imaging modality. And we're going to talk a little bit about the strategies in implementing that in the practice and how it can really refine your clinical management of patients. So I was very honored to be part of that guideline led by Sony Singh and Paul Young and an amazing group of individuals from across the country. So this was just published this year in March. Many years endeavor, but a really great product. And compared to the previous one, which was also amazing, this is elaborating on diagnoses in a whole guideline in and of itself, whereas in the past, this was a very small portion of the guideline. So we're really diving deep into the nuance of the diagnostic approach to endometriosis. I look at it like this: 5 pillars of diagnosing endometriosis. We start off with the clinical history, which Sony talked about wonderfully. The imaging piece, which often follows the clinical history, physical examination. Surgery is a diagnostic test that we've relied on for almost all of history for endometriosis. when surgery is done, or in instances where you take a biopsy of something, pathology, we rely upon as well. And then finally, biomarkers. Biomarkers are not going to be a focus of this talk, but biomarkers are definitely entering into the domain of endometriosis diagnostic journey. And so this will be something that we'll be talking about for sure over the coming years and how to integrate that. So surgery is the historic gold standard. You'll often hear people say, both clinicians, patients, sometimes endo advocates, that surgery is the only way you can diagnose endometriosis. And you must have a surgery to confirm the presence of endometriosis. This is something that is not true anymore. And hopefully Sonia's already made that point very clearly, but hopefully through this imaging talk, it'll be even more clear. Pathology, we know, relies on surgery, but pathology itself is not the panacea that we believe it to be. Like every diagnostic test, there is operator skill required. A pathologist is potentially as good or as bad as a gynecologist or as an imaging expert in their recognition of the disease. And so we must not always rely on that result. The clinical history, we don't need to go over too much because it's already been discussed extensively, but we got to see, I think, an amazing a new array of clinical symptoms and physical exam techniques that must be implemented in that diagnostic journey. The imaging piece is what we'll focus on today. For those that are really interested in understanding the nuances, the strengths and limitations of the diagnostic test for endometriosis, this is a study, a very detailed state-of-the-art review that I was happy to lead. And through the presentation today, you'll see a number of QR codes. If you're really interested, please scan. I think you'll also have access to these slides afterwards, so you'll be able to Google these as well. Let's talk about what the objectives of a test are, because this really helps us understand the strengths and limitations of each individual domain. So of course, the first and foremost objective of the test is to diagnose the disease that we're attempting to diagnose. This for me is a dichotomous breakdown. It's a yes-no concept. With a test, we also want to be able to validate patients that they have something, or reassure patients that they don't have something, or that they don't have something in a severe form, for example. So the test can really help give some nuance to the patient. From an endometriosis lens, we really want to create a map. This map is both for us, selfishly, when we're planning things like surgery. We want that roadmap, we want that visual to really understand what we're doing, who needs to be there, how long we need to book the case for. But we also want to create the map for the patients. All of you have seen the patient walk into the room that says, my right ovary is killing me, I want my right ovary out. And then you may get a scan, that right ovary may be a completely anatomically normal right ovary. And you think, how is that patient thinking that their right ovary is so painful? The key here is pain is always real, but pain is not always exactly what patients believe it to be. A narrative is created in their head based on what society tells them, what doctors tell them, what their parents have told them. And so with imaging and with other diagnostic tests, we can create a true narrative for ourselves and for patients. Diagnostic tests should also permit a dialogue. So this is one of the reasons why surgery is a bad diagnostic test. You can't talk to them while you're diagnosing them. You can't tell them what they have and what you're going to do about it. You can't have that nuanced conversation. It should permit a treatment dialogue. And within that dialogue, you should be able to contextualize their life course. Are we talking about a 15-year-old, a 25-year-old, a 40-year-old? Where are they in their pregnancy journey? If they want one, if they don't want one, if they're finished, what are their goals? Is this pain-focused? Is this fertility-focused? Is it both? There's lots of array in the endometriosis patient because they span the lifetime from adolescence and now we understand into postmenopausal years. The comorbidities are essential as well. So the test, in the case of the imaging, can also pick up a lot of the comorbidities. It can identify adenomyosis, fibroids, polyps, PCOS, all these other gynecologic things that we have to handle. And if we just are narrow-minded with endo in our mind and not those other things, we're not going to be able to have that proper treatment dialogue. We need to contextualize their comorbidities. This also applies outside of gynecologic diseases to GI diseases, GU diseases, MSK, psychology. We really need to understand the entire patient. Now, our tests are not going to always pick up some of those things, but some of them will. Physical exam can pick up abdominal wall pain, myofascial pain. These things are really important. When surgery is going to be done, imaging and a test should be able to allow the patient to make true informed consent. What is going to happen? We don't want patients to give us a blank check. We're going to go in and do whatever we need to do. No, that's not right. We should tell the patient this is what we're going to do, and that's what you should do as best as possible. Of course, in surgery, there's always going to be some degree of surprise. Nothing is ever going to be perfect, but we should be able to plan carefully. The imaging, this is my bias, but I think this is becoming more and more evidence-based, is the test overall that best meets these objectives. So the guideline outlines this. So we have a number of summary statements that are really important. Those are the key things to remember. Advanced ultrasound for endometriosis is the preferred modality and preferred over MRI. And I'll tell you exactly what advanced ultrasound is in comparison to basic or routine ultrasound. Endometriosis cannot be excluded if an ultrasound or an MRI is normal. That you already know, but that is still true with the latest and greatest imaging modalities. So here we have the differentiation between basic and advanced ultrasound. What we can see in what we know from your day-to-day practice, the reports that you receive, the basic ultrasound focuses on the uterus and the ovaries. Technically, in the SOGC CAR guidelines that depicted historically what the basic ultrasound should look at, it did suggest we should look at that rect uterine pouch or cul-de-sac for fluid or mass, but it's very vague, and if you look at your reports, sometimes you'll just see the comment-free fluid present. That's about it. And as per this latest guideline, we are suggesting that the sliding sign, which is something that's a bit newer in the space of endometriosis and pelvic imaging, can be integrated in more of a basic or routine ultrasound setting. We've suggested this to hopefully help people progress a little bit forward without dictating that they should jump all the way to the advanced ultrasound. It's a triaging tool. It's a smaller step for people. And so even though that's not what's happening yet in the community, this is what potentially can happen, a little bit more ease of access. The advanced ultrasound, on the other hand, very clearly outlines just a million more structures. We're looking at the bowel. We're looking at the uterosacral ligaments. We're looking at the vagina. We're looking at the rectovaginal septum, the bladder, the ureters. We're looking at the kidneys potentially if we're concerned about hydronephrosis. We're looking at all these structures because endometriosis can affect these structures. If you don't look, you don't see. You don't know that it's affecting these structures. And a transvaginal ultrasound or a transrectal ultrasound in some instances is actually an amazing avenue to assess the bowel. The bowel is right there on the other side of the vagina. When you have a transvaginal ultrasound, the probe is in the vagina. You can see vaginal endometriosis. The probe is touching that endometriosis. There is no reason why the imaging should not be able to capture these things. The disease is right there. So when I was a resident, this basic ultrasound made me look like this all the time. I was just perpetually confused as to why we kept accepting this mediocre ultrasound, this bad quality reports that resulted in bad surgery, inability to manage patients clinically in the office. You cannot give them information if you don't get that information from your radiology colleagues. So we're going to move on from basic ultrasound, particularly in the domain of endometriosis, but I do think over the coming years for fibroids, for adenomyosis, we're pushing forward to have advanced imaging modalities across the board for all gynecologic pathologies. We're going to see a little bit of this in some of my coming slides with the actual imagery, but there are pros and cons of the different tests. So a basic ultrasound could identify an endometrioma because the ovaries are looked at. And that should be described as an endometrioma, a unilocular cystic lesion with low-level echogenic contents. It should not be described as a complex ovarian mass. And you do not need an MRI to diagnose an endometrioma. An ultrasound, even a basic ultrasound, the picture that the sonographer takes, should be able to give you that diagnosis. Now, in some instances, it's a little bit confusing because hemorrhagic cysts can sometimes look like endometriomas. So even in my reports, you don't always get a conclusive result. We may need a repeat scan in 6 weeks or 8 weeks to reassess to determine whether something is truly an endometrioma or a hemorrhagic cyst. But at its core, a basic ultrasound can diagnose an endometrioma. It should and can diagnose adenomyosis as well, mapping that disease, fibroids, polyps, of course. So there are other things that the basic ultrasound can do, so those are some of its strengths. It's readily available to all of us. But an ultrasound is not an ultrasound is not an ultrasound. It requires the sonographer to know how to capture the pictures. It requires the imaging expert who's behind that to know how to interpret that. And so you have to understand that an ultrasound is not an ultrasound is not an ultrasound. It requires a bit more expertise. When it comes to an advanced ultrasound at this point in time, in expert hands, we believe that we can rule out deep endometriosis. We can also rule in deep endometriosis. We should be able to rule out severe bowel endometriosis, uterosacral ligament, vaginal endometriosis. Expertise is needed again, but that is what the evidence shows, that we should be able to rule it out. Endometriomas, of course, we can also see with the advanced. When it comes to superficial endometriosis, we'll see a few images of this. This remains the most nuanced or limitation of advanced imaging at this point in time, whereby we absolutely cannot rule it out. In some instances, we may be able to rule it in, but there is still a lot of people who are walking around the world with superficial endometriosis that we cannot see on imaging at this time due to its very, very small nature. So let's look at a little series of pictures. I'm not going to spend too long on this because I know most people in the audience here probably don't look at pictures, but I do really encourage you to try. You know, if you're in the hospital, if you're operating on somebody you have access, this is one way to start to close that gap between what you know surgically, you know the pathology, you know the anatomy, and what you can know sonographically. So we'll start off with a really classic structure. So here we have an ovarian endometrioma. It's a unilocular cystic lesion. It has homogeneous contents. It's ground glass, as we call it. This is an endometrioma. You're never going to see on a report from me, this is a complex cyst. That's a bad word in the ultrasound world, in my opinion, and those that are in the more international evidence-based gynae ultrasound space. What you might not be able to fully appreciate here is I don't think this one's a laser pointer, and I don't have a mouse here, so I can't quite show you. At the top of the screen, in that white band just next to the endometrioma, is deep endometriosis. We're going to look at this surgically because this is what you know. So we're peeling this ovarian endometrioma off of the uterosacral ligament. We have the classic rupture of that chocolate cyst content. And right underneath, right at that site of attachment, is deep endometriosis. Sony already showed a number of surgical views that really highlight how difficult it is to surgically diagnose endometriosis and surgically map endometriosis. I do feel very strongly that even amongst some of the best surgeons, if we don't have that map preoperatively, the recognition of that deep endometriosis in that ligament could go unrecognized, because once these planes are dissected, you really start to lose your anatomy, your structures, everything becomes red, brown, messy. This is a very classic pathognomonic view of a bowel endometriosis nodule. It's hypoechoic within the muscularis layer of the rectum. This lesion is about classic size, around 2 to 3 centimeters in its length, affecting the bowel. And you can see it's creating a little bit of a C shape. This C shape is what ultimately can cause obstruction. The more C-shaped it is, the more kinked that bowel can become. And so here we have this surgical depiction. This is at the time of the segmental resection after the excision. When you look at that surgical view just above the level of the stapler, you don't really see the bowel endometriosis. We know it's there because we've done the imaging. And when we take out that lesion, you can see that it looks exactly like the ultrasound, that lesion in my hands as we've sliced longitudinally the bowel. In this sonographic view, we have a number of vaginal endometriosis deposits. These are cystic. These are going to be those classic blue-black lesions you see on a speculum examination if you look behind the cervix, like Sony said to do. At the time of the surgery, mostly for, making a nice video, we did a vaginoscopy. We didn't need to do that for any other reason, but it really kind of highlights what those lesions look like up close and personal. But at the time of the surgery, after the hysterectomy was completed, we have that same series of vaginal endometriosis deposits. We knew these were there. We knew that in this young patient, she was in her early 30s, done her family building, wanted a hysterectomy and excision of endometriosis. We were going to have to do a very extensive vaginal endometriosis excision, potentially shortening her vagina, because look how extensive that endometriosis is. We had a very thorough conversation about this preoperatively and set her up as well with pelvic floor physiotherapy, both for management of pain but also prophylactic because of the anticipatory shortened vagina. Here's a picture of uterosacral ligament endometriosis. It shares features with the other endometriosis subtypes. It's got a hypoechogenicity. It's within that more white space around it. That's the more classic ligament appearance. This is another lesion here, uterosacral ligament endometriosis, and you know this surgically. So this is what it looks like surgically when there's no real anatomic distortion. This we can diagnose. These are small lesions. They're only a few millimeters in size. Not that hard to diagnose if you know how to do it. And then just to kind of brag a little bit, the superpower of ultrasound is in what's coming. So here I want to show you just in this area very close to the probe, there's a little black kind of hole with 2 white dots in it. You see that as I'm sweeping side to side. You can see that in a still image here, those 2 white spots, center screen. So surgically, this is the patient. So we're looking at this peritoneum in the pelvic sidewall region, and you see this little indent right there. So if we go to the video, this is a small peritoneal pocket. Endometriosis is incredibly difficult to characterize surgically sometimes, can be missed very easily. As we stretch that open, you see those 2 reddish spots at the top. That is the endometriosis within the peritoneal pocket. I would say for us in the space of endometriosis surgery, peritoneal pockets are pretty classic, pretty typical. We would likely have recognized that, but this is something that's very subtle and potentially missable. We knew that it was there preoperatively. We knew what we were going after in a very refined fashion. Superficial endometriosis, as mentioned, is something that we can rule in. So in this case, on the peritoneum overlying the vagina, again, remember the probe is touching the vagina. It's that hypoechoic darker line touching the vagina. The bright white line is the peritoneum. That's superficial endometriosis, cystic lesion. This is that specific lesion surgically. This patient also had deep endometriosis, so it was more easy to see those other lesions, but we can see very, very subtle things. Here's another patient with irregularity of that peritoneum and some white spots, hyperechoic spots we call them. This is the still image, and this was her at surgery. We can diagnose this. Expertise in the hands of somebody who knows how to do it, it can be diagnosed. Telling these patients that they have this is powerful. Even if you're not going to operate on them, it's powerful. They understand what's going on. You understand what's going on. You understand what you're treating. So I'm not going to go through all of the research, but I do want you to know, it's really important to me, that this is not just me standing up here telling you that I can see these things. This is on the shoulders of giants that have come before me in the imaging space. For over 20 years, people from around the world have been pushing forward, diagnosing endometriosis with imaging, with ultrasound, with MRI, and it is evidence-based. There are numerous systematic review meta-analyses for the various subtypes of endometriosis, for the various locations of endometriosis, and with time, we're seeing these diagnostic test accuracy scores get better, which makes sense. Technology is getting better. We understand the disease better. Our eyes are becoming more attuned to it, so we're getting better, which led to this, which was a pivotal study as part of my PhD, the ability to directly visualize superficial endometriosis. When I entered the space of endometriosis imaging in around 2017, 2018, nobody believed you could see it. There were some studies looking at soft markers for it, tenderness, thickening of a ligament. Nobody thought you could directly see superficial endometriosis on ultrasound, and I didn't really like that, so I thought, let's try. And over a few years, we pushed forward with introducing fluid into the pelvis through a technique called sonopodography. It's really an extension of sonohysterography. It's just putting a bit more fluid in the uterus, letting that fluid travel through the tubes and into the cul-de-sac pouch of Douglas, hence the name sonopodography. And this study was a prospective diagnostic test accuracy study that showed that we can rule it in. We can't rule it out, but we can rule it in. And since then, again, we've been refining that even more. Obviously, ultrasound is my obsession alongside endo, and that's the world I exist in. But occasionally, there are roles for other imaging modalities. MRI does have a role. And I would say right now in Canada, MRI probably is still the main tool that people rely on for the classic endometriosis surgical mapping in various centers around the country, because we have not had expertise in ultrasound available. And we have lots of radiologists available. Though again, you still need to rely on somebody who actually understands that disease in the center you're working in order for it to be accurate. So the guideline does tell us that we should still use MRI if ultrasound is unavailable, and in some cases if ultrasound is not an option for patients. And that's in the instance of potentially not consenting to a transvaginal or transrectal ultrasound, or too much pain during those ultrasounds, and you still want to offer them an imaging test that can achieve all those goals of the objectives of the imaging test without just going to surgery. So a pelvic MRI done by an expert, protocolized and read by an expert, can be used appropriately. CT should probably not be used in the diagnostic evaluation of endometriosis, but it can be an ancillary test for diseases that are alongside endometriosis, or in the instance of acute pain when patients present with a history of endometriosis but have an acute flare on top of that, as we, of course, still want to make sure that we're evaluating for other things on the differential diagnosis, not just endo. MRI has really the same capacity as advanced ultrasound for the ruling in of ovarian and deep endometriosis, and to a degree the adhesion state as well. Ultrasound probably has a little bit of a leg up from a dynamic nature perspective. You can push on things to see how things move. Ultrasound is static, but there are cues that radiologists use to determine whether there are adhesions present. So you can still gather ovarian adhesions, rectuterine pouch, cul-de-sac adhesions, but slightly more limited. Of course, we know MRI is expensive. There's an environmental impact to it. There are wait times to MRI, and so some disadvantages there as well. Now, throughout, I've made reference numerous times to the concept of expertise. Who can do these tests? Who's eligible? Who's accredited? Actually, there's no accreditation. There's no standardization at this point in time for endometriosis imaging. We are really still at an infancy in rolling this out across different societies. So in Canada, this guideline is the first to really start to set the stage as to what needs to be done. At the same time, the Canadian Association of Radiologists developed an endometriosis task force, which I was very fortunate to be part of, and we've put out a practice statement on ultrasound for endometriosis, and there is a practice statement coming out very soon on MRI for endometriosis. So the approach, the guidelines are starting to exist in a way that maybe in a short time we can start to define what is expertise and define how do we get people to that level of expertise that we can start to rely on those results. I'm sort of envisioning it in the same way as nuchal translucency ultrasound, whereby there is a formal accreditation process that you have to go through, but that's not yet happening in any place around the world. So when it comes to the utility of these imaging tests, really what you need to do in your centers, in your city, is find people who care. Find the radiologist, find the gynecologist, find the person there who has the interest in gynecology imaging, and start to work with them one-on-one. And we've seen this work in so many centers. I'll give you an example. At Queen's University, where Dr. Olga Bougie was recently, before she's moved to Toronto, she established relationships with 2 champion radiologists and a few champion sonographers, and started an endometriosis imaging program there, and relied a little bit on my expertise through a visit, through hands-on training, to start to upskill that team in that center. And so everybody in every city has somebody who's interested, I hope, and can find relationships there to hopefully allow the introduction of this. We do have the literature to support that expertise matters. When you look at diagnostic test accuracy studies that assess junior faculty versus senior faculty, we know that the accuracy improves with more skill, more learning. This hopefully has already been clear. We cannot rule out endometriosis on imaging. Specifically, we cannot rule out superficial endometriosis on ultrasound. A normal scan, regardless of the modality, does not mean the patient is normal, does not mean that they do not have endometriosis. This is something that needs to be verbalized to the patient. Patients sometimes interpret a normal scan means I'm okay. I mean, they know that they're not, but they start to internalize this normalcy of their symptoms, which ultimately leads to the development of that central sensitization that we know about, which I think is somewhat being better named at this point, pain system hypersensitivity. It's a concept that actually further drives their symptoms. So when I have a normal scan patient, I say, your scan is normal, which is reassuring. We can rule out deep endo, ovarian endo, adenomyosis, fibroids, all these things, but this doesn't mean your pain is normal. This doesn't mean that it's okay. It doesn't mean that we're not gonna help you with it. We're still gonna help you. And this is when we come back to that concept of the clinical diagnosis, the presumptive diagnosis, if we believe that to be the case, based on the patient's signs and symptoms and examination. I'll just touch upon surgery for a second here because the guideline does touch upon it, but mostly in the context of preparation for surgery. So as a diagnostic test, you should be able to put a scope in, visualize all the structures, of course the pelvis primarily, but also the small bowel, the appendix, the diaphragm, the liver. Really, you're doing a 360-degree assessment. We should be taking pictures. I know that's not actually available in a lot of centers. We can take pictures, but we can't actually upload pictures in our center, which drives me crazy. And so that's what we should be doing. But we need to take a more global look because, again, endometriosis is a systemic disease, not a gynecologic disease. And if we're going to do surgery, we should try as best as possible to be prepared for that surgery because most of us anticipate surgery for endometriosis is going to be therapeutic, not simply diagnostic. We're anticipating if we're going to go in and we're going to find something, we're going to treat it. But you need to be more prepared for that. So let's show you the evidence here. Surgeons are, first of all, not that good at diagnosing endometriosis at surgery. This is both in the context of some forms of deep endometriosis that are quite easy to miss, but also some forms of subtle, superficial endometriosis that might be missed. And also, we're learning a little bit more about even occult endometriosis that's microscopic, not visible to any of us, even those that are devoted to endometriosis as their primary disease in their practice. So surgery has limitations. What you see on the right side of screen is a sigmoid colon view, different than the one that Sony showed, but actually not that different. You can see those epiploica being pulled in and over the serosa of the bowel. We knew there was bowel endometriosis there because we saw it preoperatively. We knew that we were bringing our colorectal surgeons to this particular patient's case. We knew we were going to be doing a segmental bowel resection. When you remove that segment and you open those epiploica, the endometriosis shows itself even more. When you do a longitudinal slice down that, it looks exactly the same as the sonographic view. So surgery is not great as a diagnostic test. When you are doing it primarily for therapeutic reasons, but you're still kind of further creating that narrative, painting that diagnostic picture, hopefully we can start doing that with language that we can all agree with and we can understand each other. So we do have a number of staging systems that exist, ASRM, the Enzian scoring system, the endometriosis fertility index, and the newer AAGL endometriosis classification. Our guideline does not recommend any particular staging system at this point in time, as none of them have a perfect utility, particularly from a prognostic standpoint. And so there's no real recommendation now, but there is a goal, of course, for standardization. And through the World Endometriosis Research Foundation, there is a surgical standardization tool that you can use. It's available to download for free on the WRF website, and it kind of outlines how you should, in a more granular way, document an endometriosis surgery assessment. Not what you do, but what is there. I've already highlighted the pathology as part of the guideline as well, but we also note in the guideline, again, like all things, there is an operator-dependent nature to this. So in some cases, it may not be identified. We do have some literature showing that modified pathology approaches actually increase the diagnostic pickup of endometriosis, which makes sense, again, like imaging, like surgery. If you don't look, you don't see it. So you need to look in a comprehensive way. So just to conclude from the understanding of how the imaging has come to the forefront in the guideline. How do we use it? So for me, the approach to the utility of imaging comes in a more individualized and autonomy-driven care model. Understanding the map and the context allows me to talk to every single patient differently. I don't think about endometriosis as a black and white disease where everybody comes in and we have a first line, second line, third line approach. We do have to customize the approach to the patient. And so I break this down into a few different ways. The subtype of disease, so are we talking about superficial, ovarian, or deep, or some combination of them, and which organs are affected. So in this case, this patient is just superficial endometriosis present. This particular case, we have obliteration of the cul-de-sac with bowel endometriosis, pathology involving the tubes, the ovaries. This is a much more complex case. Here we have vaginal endometriosis. These are all different patients. Bilateral endometriomas fixed to each other, fixed to the posterior uterus, tubes pulled in. This patient is going to have fertility issues, almost no doubt. And in this particular case, you don't even see any of the organs other than the uterus. There's a complete wall between the bowel and the uterus. We try to understand the nuance of these different patients because their care approaches are going to be different. We try not to, again, just use the exact same medley of treatment options for each of these different cases. But then the nuanced approach also extends beyond the type of endometriosis and the organs affected, but to the concurrent gynecologic pathologies, as well as their other bodily pathologies, their comorbidities. And so in my center, and I know a lot of the other individuals in the room, Catherine, Sony, Annie, all kind of think outside of the gynae box. We think about GI, we think about GU. These are the most direct organs that are affected due to the mechanism of cross-sensitization in the pelvis. We think about the neurologic and the psychological approach to patients who have chronic pain and the musculoskeletal aspect as well. If we can break it down like this, it's a little bit less overwhelming for us in some ways because we have a more structured understanding of how this disease can affect people, but we can also then ask for help from our team members that are in these individual spaces. Like Sonia referenced, when we see the endometriosis patient in the office, it can be quite overwhelming because they want us to fix everything. They come in and think everything is endo. And endo does have its arms and web into all these other systems, and so we need to be the leader of that team. But we really do need to ask for help from our colleagues in GI, in urology, in the space of psychology and sometimes physiatry, neurology, and pelvic floor physiotherapy. The approach to this patient is more multimodal, and you can really enhance that treatment approach by refining your diagnostic approach. And so one of the things I often say is diagnosis is the gatekeeper to therapy. This is not revolutionary, this you know, but if you break down that endometriosis diagnosis into a more parts aspect, where you're understanding things a little bit more granularly, you can then deliver a more refined care approach. It looks like this for us. We have the patient who's got the possible endochronic pelvic pain, very comprehensive history and physical examination, very advanced imaging that we do in our one-stop shop clinic in our office. And these are the goals. We want to achieve the diagnosis and potentially diagnoses. We want to get a mapping, a severity assessment, the diagnoses of these comorbidities, adenomyosis, polyps, fibroids, these other things that are going to impact on our ability to care for a patient with endometriosis, and again, their context. When you have all this information, and it does take a while to collect it because this is a complex history and physical and imaging test you're doing, you then can actually discuss the care plan with the patient. If you really are taking endometriosis at a modern approach, it's going to look more like a buffet approach, a multimodal approach, where patients are looking at agents, options in different categories, not just one agent only. You're usually not going to succeed with a simple prescription of Marvelon or Dianagest. You're going to need to think more outside that box. And so the buffet approach that we take involves a lot of complementary and alternative strategies. The core three that we really do rely on are pelvic floor physiotherapy, registered dietitian, and pain psychology. There are others that we do rely upon a little bit depending on that individualized approach, but we are really heavily relying on those allied healthcare professionals. Medical management, still a mainstay, achieving amenorrhea, very, very key. I'm not going to talk anymore on that because there'll be other talks on managing endo, and surgery. And again, when you're doing surgery, knowing what you're doing is key. If you go in unprepared, outcomes are going to be poor. If you don't know, because the history is too little, if the imaging is inadequate, you can't have that conversation with the patient. They're not going to get counseled correctly. You're not going to be able to advise them or convince them on what they should do, and so you really are stuck. So this is what it should look like from a diagnostic algorithm standpoint. You start with the history. You talk to the patient, and we have suspicions raised, flags raised when you're talking to the patient. You may at this time give people that presumptive clinical diagnosis. We believe you have endometriosis. But you know it never stops there, and it should never stop there. We do an exam. In the instance of vaginal endometriosis or an umbilical wall or abdominal wall endometriosis lesion that's actually visibly noticeable or palpable, then you may actually have a even more suspicion at that point in time, or potentially even diagnostic. If you see the vaginal endometriosis, there's nothing else that is that. After that, you move on to imaging. Presumably in most communities, we're going to be implementing still more of the basic imaging, but if you do have access to more advanced imaging, you should be using that straight away. Skip the basic stuff because you're just not going to get as much information. In the context of an ovarian endometrioma, diagnosed on basic or advanced, you have the ability to diagnose the patient. With advanced imaging, you might pick up deep endometriosis, superficial endometriosis, or adhesions, which are more of a soft marker but still can be diagnostic of endometriosis. If the imaging is negative and you haven't found anything on physical exam, then you're at an impasse. You have the decision now to either provide them with that clinical diagnosis and provide treatment based on that, but alongside that, a lot of reassurance because you have comprehensively evaluated lots of things in them and also ruled out a lot of severe things. Or you can consider laparoscopy as a diagnostic test, but that should be used more if you're going to also be doing therapeutic approach to it as well. So to conclude, in my opinion, diagnosis is not just the gatekeeper to therapy, but it is also therapy. It is a way that we can validate patients. The tears that come when you diagnose a patient with endometriosis are common for us. When I turn the ultrasound screen to a patient and show them their endometriosis, they often do cry. This is a very validating experience and has immense impact on that whole journey. So my very last slide is a short video that we developed in our team because we really feel very passionate about driving the agenda forward, being in the driver's seat of the imaging and how that impacts surgery. So I hope you enjoy this little short film. And I'll happily take questions after this.
For decades, surgeons relied on vision and touch alone to navigate the complexities of the human body. But today, we stand at the threshold of a revolution, a transformation where technology and human skill unite to push the boundaries of what's possible in gynecologic surgery.
In the hands of the modern gynecologic surgeon, ultrasound has become more than a diagnostic tool. It's a guiding force, a window into the unseen. Every movement informed by precision, every decision refined by real-time clarity. This is the new era of surgery, where technology empowers surgeons to go beyond the ordinary, to unlock a world of insight with every scan.
We no longer rely on intuition alone. The fusion of ultrasound with minimally invasive surgery has transformed the way we treat complex gynecologic conditions. Surgeons now hold the power to diagnose, plan, and execute with unparalleled level of certainty, redefining what it means to deliver patient care. From the first moment of diagnosis to the final suture, the integration of ultrasound shapes every step of the journey.
Ultrasound has brought a new dimension to care. It allows us to see what others cannot, to plan with precision, and to deliver the highest level of care. Our patients no longer face uncertainty. They benefit from a care plan rooted in the most accurate diagnosis, with surgeries tailored to their unique needs.
Surgeons, sonologists, these trailblazers have embraced this technology to refine their craft. each scan a step closer to mastery. These pioneers are not just surgeons, they are visionaries guiding the future of gynecologic surgery with confidence, clarity, and compassion.
This is the new generation of surgeon sonologists, leaders who are shaping the future of gynecologic surgery, not just for their patients, but for the world. Through their hands, the boundaries of possibility are redrawn, their expertise lighting the way for those who will follow.
Each member of this growing army stands as a testament to innovation, to the relentless pursuit of excellence. Together, we're more than just practitioners, we're advocates for a new kind of surgery where technology enhances human ability and transforms patient outcomes.
The future of gynecologic healthcare lies in the hands of those who are unafraid to innovate, to challenge the status quo, and to wield the tools that transform lives. Power of ultrasound is in our hands. Are you ready to embrace the future?
It's a bit dramatic, but thank you.
Great. So we do have time for questions, and then after this, we have time for a really nice network break for half an hour, and then we'll follow up with Dr. Allaire afterwards. So I'll start with the audience here. We have a question, then I'll go back and forth to Zoom. Go ahead and just tell us where you're from and what your name is.
Hi, my name is Dr. Helen Pymar. I work in Winnipeg, Manitoba. I'm part of the training for ultrasound for residents in their first year. I'm really interested about that fluid contrast that you had, and I saw a little, looked like a Foley. Can you just describe a little bit more about where you're putting that Foley and how it's, and how the comfort? I'm also wondering about how well they tolerate it for that contrast.
Thank you for the question, Helen. So the fluid that we infuse is done through an ultrasound procedure in the office. It's like a sonohystrography. So probably everybody here may have experienced sonohystrography on their fertility rotation. You place an intrauterine balloon catheter and you infuse fluid. The experience with the endometriosis version of it, the sonopodography, is not dissimilar to the regular sonohystrography version, except the population is slightly different. This is often a more pain population, and so they do have a bit more sensitivity. At baseline, for any intrauterine procedure, I do use local anesthetic, and we have actually started to integrate Penthrox, the green whistle, into our clinic for biopsies, IUDs, and these procedures. So they actually tolerate it really well when you offer them analgesia, but even without, most do tolerate it like they do a sonohystrography, so they tolerate it. It's not usually pleasant. And then once that fluid's there, that's when you look for the additional endometriosis.
I think what Helen was talking about was on the video, you had a Foley going through a laparoscopic port, and we were wondering what that was about.
Oh, okay. Well, that's a published case, actually. Dr. Hanan Al-Salem, who's in Ottawa, published this amazing case of a patient who we picked up in pregnancy at 17 weeks with a 30-centimeter uterine mass, completely cystic uterine mass. And she wanted to keep the pregnancy, even though it was literally up in her liver, the fetus. So we did a ultrasound-guided laparoscopy where we drained it and then placed a Foley catheter in until she got to 33 weeks, which was a great success. And then she got infected, but she got a 33-week baby, and she's happy. The baby's happy. So we'd used ultrasound to actually help an obstetrical patient with a gynecologic pathology. It was like probably the most amazing case of my career so far. And if you want to watch that video, it's published in the Journal of Endometriosis and Uterine Disorders.
So, so in conclusion, then you're doing a sono when you inject the fluid through the uterus to get that view. The only thing I'd just share, and if I can add, is if you do have people with severe endometriosis and endometriomas, and they're getting any procedure done, like a saline infusion ultrasound, please consider antibiotics. I've seen enough septic cases, people who've gone close to death because of that. So I don't know if you do normally give them antibiotics if they have an endometrioma?
If they have any severe endometriosis, yes. Like we do a lot of sonohystrography tubal patency testing with ultrasound. Anytime that there's severe endo or obvious tubal pathology, they get prophylactic antibiotics.
So that's a tip for you, for those of you who don't do the ultrasound yourself, but you're referring somebody, please give them, it could be as simple as I just give doxycycline
5
for
days,
5 days.
Yep.
Okay. Just because it's Nick next, I'll go to him, then I'll go back to Zoom.
Hi,
Nick Leyland, McMaster University. Just what you guys are doing is fantastic. It really is an amazing improvement and movement ahead for women in Canada. And one of the reasons why I've become more involved with the SOGC is because I think advocacy is such a big part of what we've been missing in all of these different areas. So it's extremely important for us to push at various levels to address these issues. And I wrote down a whole bunch of things that I could talk about, but we can do that offline. But I think what's interesting about this disease is it is very frustrating. And most people start out, you know, at least I did, thinking this was a surgical disease and we just have to learn the tools to be able to figure out where the disease is and pick it up. But and imaging has an incredibly useful role to play. But most of us find that these patients are actually much more complex than just endometriosis. Many of them have chronic pain syndromes and central sensitization, but many of them come, especially when they've had an imaging diagnosis, thinking, based on some perhaps misinformation in the media, that they just need the right surgeon and they will be cured. I mean, some of our American colleagues are trolling for Canadian patients all the time with this in mind. But really, it's a much more complex disease, as you say, and you've indicated. But I fear sometimes when we do tell people that they have disease here or there or everything else, then they are actually really going to push for a surgical approach. So how do you deal with that difficulty, and how do you deal with patients who clearly may not benefit from additional surgeries?
Absolutely. Great question. Thank you, Nick. And, you know, not because he's at the podium, but he's the one that gave me the chance when I wanted to come back to Canada with this crazy agenda of doing advanced imaging and combining that with surgery. So without his support and welcoming me to McMaster, I would not be up on this stage, and we would not have this revolution with that list of names of people that are now kind of around the country. But, you know, he's always challenged me, which is good, because, you know, you have to be challenged to kind of think critically about these things. Essentially, you know, the first thing that you need to do when you see this patient in the office, even if there's visual endo, is you need to understand the context. I use the Central Sensitization Inventory Score as a routine tool, and published literature out of the UBC group shows us that patients who have a score over 40 don't do as well as surgery. Doesn't mean that I'm not going to consider surgery for them, but that comes into the conversation around whether we do surgery or not, even if they have visible disease. So the context really matters, painting that very thorough picture of the patient's story to decide with them, you're in the passenger seat, they're in the driver's seat, how to guide them as to their decisions. But one thing I usually don't do, and I think this is a good strategy, is I never take surgery off the table. One thing that I have noticed about endometriosis patients is that they have this sense of loss of control. And really, they have lost a lot of control because this disease is so bad. It has taken over their lives. But what also has done that is perpetual paternalism in medicine, is the declining of certain things, or the necessity that you must try this before you can have that option. And so I try not to take things off the table for patients, hence the buffet approach. And what you will be so surprised by is that patients that are offered surgery or surgeries on the table, a lot of them don't want it, because people don't always want surgery. And so you do have some patients who walk in the door and on their intake form they say, I'm here for hysterectomy and take everything out. And then there are people who are a lot more reasonable. And so when you do offer them the options, you give them control, you give them autonomy, that helps your relationship. I do believe it also helps with the outcomes, even of the options that, you know, maybe are the traditionally less popular options, including medical therapy. So I hope that answers the question. I mean, it's definitely something we're going to face. Visible pathologies tend to go along more with removal of those visible pathologies. But also, as a person who's an academic and asks questions literally sometimes in my sleep, I don't know, maybe we need to question whether some forms of endometriosis do need to be surgically removed to prevent the progression of the disease or limit infertility in the future. We don't know these things yet because we've never been where we are, where we have the comprehensive ability to understand these patients non-invasively. So we have a lot of research to do, essentially.
So I'm just going to go to Zoom. Okay, is that okay, Dr. Waja? I'm one of my favorite people in the world. Is that? I'll just delay that. And one of the best surgeons, if you ever get to work with Dr. Waja. So online, I'm going to actually move to a question about POCUS. So next week we have a sold-out course for OBGYNs in POCUS in Ottawa, and because we haven't really seen that happen. And so there's actually, I think it's a student, it may be, who is asking, in medical school, they get tons of POCUS, more than the staff actually have ever had. And it's being led by Emerge, it's being led by other services. And her question, or their question, sorry, is there a role for increasing pickup in the office so that people actually can start to look on their own?
Very good question. Thank you to the online audience member. You know, there's a growing utility of ultrasound in lots of specialties of medicine outside of radiology, and that's becoming increasingly recognized, and it's possible to bill OHIP or other provincial health programs. So I do think that we have to take the probe into our own hands. If you look at models of care in other places around the world, in Europe, every gynecologist knows how to scan. In the Middle East, most gynecologists know how to scan. South America, most gynecologists know how to scan. There's countries where they don't even have sonographers. I'm not suggesting that that's the world we go to, but I'm suggesting that we need to be the bearer of this responsibility, because it is a tool that is no radiation, easy to use in the office. In some ways, it does replace certain aspects of a physical exam. Like, you know, I don't really need to feel if there's fixation because I can visually see if there's fixation. And I think what we're going to see with the ease of technology, the smaller sizes, the cheaper technology, that we will eventually be able to have ultrasound in our offices. We'll just have to work with the mechanics with SOGC in Ontario in terms of, you know, how does that actually bill and how do we do it? How do we report it? How do we feel covered from a CMPA standpoint? For what it's worth, I didn't have to get any additional CMPA coverage to report ultrasound. As an OBGYN, you have the full ability to report ultrasound and be covered for it if you have an expertise.
So quick question to the audience. How many of you regularly do POCUS ultrasound in your offices? Very few. So, you know, just like when we got laparoscopic hysterectomies going and other things, I'd like to see this whole room put up their hand. This is back to what can we do immediately? It's a bunch of questions. First of all, let's just get the ultrasound in your hands, take these programs. It's not rocket science. If Mathew can, no, sorry, if I can do it, anybody can do it. Wouldn't you agree? Like, we
Absolutely.
should be, everybody in this room
It's a skill that you can learn.
Yeah.
And truthfully, you know, the learning curve for an individual who is a gynecologist, who understands the patient, who understands a speculum exam, a pelvic exam, who understands laparoscopy, the learning curve is actually quite short. If you try and implement that learning curve to a sonographer who doesn't talk to the patients, who doesn't examine them, doesn't know about endo, that's a long learning curve. Radiologists also don't understand the disease like you do. So the learning curve for a gynecologist to do ultrasound, for endo or for other pathologies, and there's certainly some much more simple things like polyps and fibroids, that's not a hard learning curve. I do think that in my career, by the end, everyone in this room will have their hand up. Actually, I don't think I know, because that's my objective. That's my goal. In my career, everyone in Canada who's a gynecologist will be scanning.
Putting an IUD under vision is incredible. All these cases that we get referred where people have had difficulty entering the uterus for a biopsy, just having the POCUS there makes me look like a hero, and it's not. It's just under visualization. Dr. Waja.
Lukman Waja from North Bay, Ontario. So just a point of clarification on the previous question about surgery prior to IVF. So in the circumstance where there could be hydrosalpinx bilaterally, should surgery be considered prior to IVF? Because, I mean, that's something that we did consider in the past for improving the outcome of IVF, actually.
No, very good point. I think that's so the question in general, I think the way I took it was, do you routinely do surgery for endometriosis before fertility? It is a discussion. So now you're identifying if you have a hydro or hematosalpinx prior to IVF, that is still one of the standards of care to remove it to improve outcomes for IVF. Mathew, do you agree?
Yeah, I agree. But it's a very nuanced conversation about the order of events. Do you do IVF first, or do you do the surgery first? Certainly when there's an endometrioma, I'm on your side. I really do recommend these patients pursue IVF first, either for development of an embryo or freezing eggs, and then surgery if indicated, and then put the embryo in afterwards.
Thank you.
Thank you. The follow-up on that person who asked the question is from Quebec, and our Quebec colleagues would attest to they have better training in imaging.
Yes.
This is a medical student
Yes.
who I'm sure will feel comfortable doing POCUS ultrasound in the office better than all the staff that in Ontario who haven't
Yeah.
gotten that. So I think we will, our students will know more,
Yes.
and we need to do that better.
On the topic of Quebec for just a very quick moment, so my fellow who's graduated, who's now in Montreal, Dr. Melissa Marianne, she teamed up with Dr. Sarah Mahi-Lacroix in Quebec, and within a few months of Melissa being back in Quebec, they have already introduced an endometriosis ultrasound code with their government. So, they pushed really hard and fast immediately upon her return, and now they have a code that they can bill to do endometriosis ultrasound. It's amazing. Like, I don't know how that happened so fast because bureaucracy, but it did. So change is possible.
Great. I have a question here.
Angus Murray, I'm from Truro, Nova Scotia. I'm in a smaller community. We have in the hospital a small ultrasound in our labor and delivery clinic. It's like a laptop. If we had a transvaginal probe for that, was that a good enough ultrasound to do what you're doing, or do you need? Because it seemed like you had a bigger diagnostic imaging kind of scanner.
There's an array of equipment, even equipment that's a little bit older or smaller can pick up certain aspects. And if you're using it more as a triaging tool, for example, want to implement the sliding sign, I think you can. I actually do think that you can use equipment that's, not top of the line or, what you might expect in a tertiary center. But if you're going to try and look for uterosacral ligament endometriosis, bowel endometriosis, you might struggle a little bit with that level of complexity. But starting small with certain tasks like sliding sign, it's an amazing tool. If you're even in a non-endometriosis population, a hysterectomy population, just thinking about it, is there severe adhesions between the bowel and the uterus? Should I do this surgery or should I refer the surgery? That sliding sign can be a great tool and anybody can implement it.
So I think we're going to take a break because we have a panel time, but the last question, I think you said you were from Truro, Nova Scotia. That's where we need even more support. And Ontario, in rural settings or even smaller settings, that's where we need those codes for you to be able to do those on your own until you get your radiologist on board. Okay, one last question snuck in there, so then we'll go for a break.
Hello, thank you for your great talk. You're Dr. Sonitoo. I'm Sepideh. I'm gynecologist from Iran. I was working in Endometriosis Research Center in Iran. And I want to tell you my experience here. I started to work as a medical sonographer here 2 years ago. And I knew the importance of diagnosis endometriosis on time and the sonographic features. And I started when the patient came with the complaint of pain for pelvic ultrasound. I tried to do more precisely imaging and looking for sliding sign and other features of endometriosis, and to report this report on the report sheet for the radiologist. But after a while, I got a call from the radiologist. He was a very well-known and knowledgeable radiologist in Toronto, that you should not do that. It's not the scope of practice. It should have been done in the hospital, in educational center. After that, I stopped reporting just. I do for my curious, but I don't report to the radiologist. But yesterday we have another topic about the fibroma. There was a lack in reporting too in that session. I think there is a missing part is lack of collaboration between gynecologists and radiologists, because most of the sonologists don't have expertise to diagnose the endometriosis and don't know the sonologic features of the endometriosis. And our experience in Iran was that we collaborated with some radiologists who are expert in gynae ultrasound, and we referred all patients that we were suspected to have endometriosis to those radiologists, and it was great collaboration.
Great. Thank you for your comment.
Yeah. Sorry that that's been your experience and you know this information that the patient deserves, but now it's being withheld. That's not so great. It really speaks to the necessity to work together right now with our radiology colleagues, and that is happening on a Canada-wide scale. How it eventually trickles down to every community radiologist remains to be seen, and probably will take quite some time. When I was in Sydney, where there is a similar model of care with sonographers and radiologists or sonologists, Sometimes the sonographers would tip the patient off in a sort of subtle way, like maybe you should go to an expert center for an endometriosis scan or, you know, an advanced ultrasound, because, you know, there's a suspicion. Whether that's like ethical or legal, you know, well, it's definitely probably moral, but that's something that some of my sonographer colleagues would do. But they also kept pushing their radiologists and kept saying, you know, we need to be scanning for this. And I can tell you at the level of Sonography Canada and the Ontario Association of Medical Radiation Sciences, which actually drives most of the education across the country, they're getting a lot of endometriosis content. So the sonographers potentially are going to outpace the radiologists in Canada from an endometriosis ultrasound lens. The radiologists are going to have to keep up.
I have to close the session so that we go ahead and have a break. So 20 minutes, go get yourself refreshed, and we'll see you back. Thank you.
Thank you.